Welcome everybody. I'm Dr. Poplowski and I'm a bariatric surgeon. That's a general surgeon who has decided to specialize in this field. And I've been doing this about 16 years now, about 4,000 cases. Bariatric surgery is surgery that helps people to lose weight. Baris is a Greek root, means weight. Barristers, the lawyers with the scale, barometric pressure, weight of the air. We treat a disease here called morbid obesity, which sounds kind of bad. I think the first time you heard that, you probably wanted to slap somebody, but it's just two medical words. Obese, a condition of too much body fat. Okay, you can live with that. Morbid doesn't mean bad or ghastly or unsightly or anything like that. It actually means now in a diseased state. So a condition of too much body fat that has progressed to a level where it's starting to cause other diseases like diabetes and hypertension and sleep apnea and destroyed joints and reflux and asthma and premature heart disease and liver failure and bladder dysfunction and top to bottom. Illnesses that are the direct result of too much body fat for too long. Things that are damaging your health, shortening your life, and taking away a lot of fun. Now, the first line of treatment for morbid obesity is to eat less and exercise more. Anybody tried that yet? Yeah, right. That's plan A through Z. And when that doesn't work, then the next thing is to work with a real doctor. See, is there some medical reason why nothing's working? Is my thyroid okay? Is there anything else going on? Is there anything that they can do in their office to help you control this life-threatening illness without an operation? Because nobody really wants an operation. So diet pills, nutritional therapy, exercise counseling, all of these things could and should and ought to be given a reasonable try until it seems unreasonable to keep trying, and that's when it's time to talk to us. Okay, so this is not the first line and it's not the second line, and what that means then is what I get to take care of here are the failures, another hard word, of the medical management of obesity. By definition, people that come for operation, should have given these things a reasonable try, and if it doesn't work, then you get to see us. And for me, the interesting question is not, does this patient qualify? That's pretty simple. I get out the chart, I look up your height and your weight, and either you're above the line or you're below the line. But the really interesting question to me is why? How did this happen? How come these normal, intelligent, educated, hardworking people can do whatever they want in life except control their weight even though their life is in mortal danger? What's up with that? And the answer to that question, I believe, is probably going to turn out to be the key to lifetime success after bariatric surgery. How did this happen? Why did this happen? Why did I do this to myself? Why is this so hard for me? And the more sophisticated I think you make yourself at understanding that, I think the better this is going to go in the long run. Bariatric surgery will help you lose weight. It'll help get you back started. But long-term, lifetime weight control will require that you begin to identify and heal and fix and change the behaviors that made this necessary. And being able to talk to a counselor, a therapist, a psychologist, why is this so hard for me? That's a good idea. Blue Cross makes everybody go. If you have a Blue Cross plan, you'll have to see a psychologist at least one time before they agree to pay for it. And obviously, I don't want to do bariatric surgery on somebody who's so mentally ill they can't take care of themselves, they can't really make an informed choice, but that's not usually the problem. So regular old working Joes, got to see a psychologist. So I tell my patients, as long as you got to go, try to get something out of it. They're going to ask you all these nosy questions because that's what they have to do. And when they get done and they say, do you have any questions for me? This is what I want you to say. I want you to say, yeah, why am I here? Why do I need this silly operation? What's going on? Why is this so hard for me? And if they say that's a really important question, and when you're ready to start talking about that, I'd like to help you with that. That's the right answer. Because that day will be about checking off the Blue Cross box. And, but being able to start that conversation to learn more about what brought you here, I think will be really important. After surgery, if you find yourself starting to struggle against the operation, you get back in. Talk about what's going on now. For some patients, for some women especially, as their figure comes back and how people react to them changes, sometimes it becomes threatening. You know, they don't like that, and they become threatened by the changes, and they do things to defeat the operation just to stay safe. If you find that your partner, your spouse, your husband, your wife is starting to do things to defeat the operation, you get in together to find out, what are you afraid of now? I tell all the married women that during the first year you have to tell your husband at least once a week in plain, simple man language. Don't be subtle, don't be indirect, just say, Bob, I'm not leaving and I'm not seeing anybody. The guys get weird during the first year. They see all this energy and everybody's telling you how good you look, and he's wondering, what is this beauty going to do with a mutt like me? And they start to fantasize that you have to leave, or they start to fantasize that everything's going to change. And I see it happen so often. I warn everybody, don't let this happen. Okay, keep this one right on top of the table. Talk about it when you get home today. The doc says that during the first year I'm supposed to tell you once a week that I'm not leaving and I'm not seeing anybody. And if you start worrying about that, we need to talk about it. A lot of changes happen, and it'll be an interesting year for you. What the bariatric surgery really does in the end, though, is it helps you control the size of your meals. No feasts, no seconds. But that's all it does. And you still have to stay away from the bad foods. And the way to defeat bariatric surgery is to nibble on high-calorie foods all night. So you have to be able to avoid that kind of behavior. Our very best hope for bariatric surgery, I believe, is to take this long-term, lifetime, life-threatening illness and put it into a long-term remission. And think about it that way. You know, we don't cure it. We don't cut it out. We don't make it go away. We will help you control it, help you get it under control, but at the same time, you got to be prepared to take it on from there for the rest of your days. And the quality of the rest of your days, the quality of the rest of your years will depend on us getting this problem under control. So that in your 50s and 60s and 70s, you have good enough health to have some fun, to be mobile, to, you know, be able to enjoy yourself, enjoy your body, enjoy your sexuality. Okay, so that's what we do here. We do bariatric surgery. You know, I used to think it was about an operation. I used to think, you know, you take these complex patients, you do this very difficult operation, just perfect, get them through it, get them home, and bada bing, problem's gone. That's how you take care of an appendix. Okay, this is different. It really is different. And the more we learn about it, the more we have to understand that this is a chronic illness, and we're going to help you get, you know, do some things to get it under control. But then you have to take it from there. And I think that's what the big challenge is in modern bariatric surgery is now, is lifetime weight control. You know, not just get through the operation, but rest of your life. And that's what we're shooting for, okay? So we do 2 operations here now to help people control their weight. We do gastric bypass surgery, and we do sleeve gastrectomy. There was a time when we did a lot of the adjustable gastric band or the lap band, but that's pretty much gone away now. Anybody really interested in the lap band? Okay, it's going away. I think we should let it go away. You know, for some, you know, it was so popular for a while because it was so easy and so safe. And people thought it was less invasive. That always confused me because I thought it was totally invasive. You know, I have to go into your body to put this in. But it went through a big period of wild popularity, but then it went away because of long-term complications and just plain old ineffectiveness. Now, it was by far the safest thing that can be done. It's about as safe as putting somebody to sleep and waking them right up. But as far as long-term complications, that's what's made it go away. Every now and then, though, somebody will come in and say, you know, I understand that the band is the safest, and for me, that's the only risk I want to, or only risk I can assume right now in my life. So for me, it's the band or nothing. We'll talk about a band. Help you, you know, put it in for you and help you take care of it the best I can. Somebody will come in and say, I've been studying this for 3 years, I still want that band. Okay, let's talk about it. If that's what you want, we'll put in a band, help you take care of it the best we can. But I think most people can be served a lot better with either a sleeve or a gastric bypass. So I'm going to talk about both of them, and everybody kind of has an idea of which one they want because they know somebody that had it did great, know somebody had it didn't do so good. But listen to both, and I just want you to be able to make an informed choice for yourself, which one you want. Okay, so let's start out with the gastric bypass first because it explains a lot of anatomy and physiology. So your esophagus, your swallowing tube, starts in the back of your throat, goes all the way through your chest, and then when it gets in the belly, it enlarges and becomes a stomach. And then it gets small again and becomes a small intestine, and there's about 16 to 20 feet of small intestine all coiled up in there. Your liver's on the right side. There's 2 tubes that come out of the liver. The liver makes bile from old broken down red blood cells and puts that bile into the first part of your intestine, and bile works like a detergent, like a soap, to help break down the oils and fats in our food, help make them easier to absorb. Your gallbladder's here. It stores bile when you're not eating, and sometimes it gets stones in it. If one of those stones gets wedged in there, that's when people get sick with their gallbladder and have to get it out. Your pancreas is a digestive gland behind everything on the left side, and it adds into that same little opening enzymes that help us digest fats and proteins and sugars, enzymes. So we swallow the food, comes down the esophagus into the stomach. The stomach doesn't really absorb any nutrients. The stomach's just a storage bag. Lets us eat as fast as we can shovel it in and then run with that food in case we need to. There's a muscle at the bottom called the pylorus, and it's like a muscular ring or a donut that squeezes the bottom of the stomach closed. And normally it's closed. If you look in there with a scope, it just looks like a little pinpoint. A couple times a minute, that muscle will relax, let out about a tablespoon of food, and then squeeze down again. Has its own rhythm. And that rhythm is determined by how much fat and sugar's in the food. So that little bit of food comes out, it mixes with the bile from the liver and the enzymes from the pancreas, and that chemically starts the digestion. And then as the food is moving through your small intestine, the nutrients are being absorbed into your bloodstream through the microscopic blood vessels that line the wall of the intestine. Now, in the gastric bypass, we divide your stomach into 2 stomachs. A very small upper pouch that's separated from the main body of the stomach. We don't take out anything, we just close those ends off so that they don't leak and the 2 never join again. We measure from the beginning of the intestine down about a foot, foot and a half, and then we divide this like we're cutting this 16-foot hose at 1 foot. We take the far end, the long end, the end that would keep going, and bring it up to here so that that X ends up there. So I'm going to bring this end up to the upper pouch. This end here we're going to sew to the side. We're going to make a connection here. We're going to make an opening in the upper pouch. We're going to make an opening in the intestine, and we're going to sew those 2 openings together. So now the food goes this way. Okay? Acid is made in the lower part of your stomach. It still works, has its own blood supply, nerve supply, still responds to stimulation from your brain, still makes acid, but this acid can no longer reach your esophagus. So the heartburn's gone on the first day. For some people, that's a really important improvement. After their gastric bypass, they no longer have acid reflux, no longer have heartburn, and usually when that gets better, the asthma gets better. But the lower stomach still makes acid, the liver still makes bile, the pancreas still makes enzymes. Altogether about 3 or 4 liters a day of juices are being made and are carried by this 1 foot and put in downstream here now. Well, hi. Everything only goes one way in the intestine. Can you see from there? Yeah. Okay. The distance between this connection here and this connection up here is actually about 5 feet, all coiled up, about 8 to 12 feet beyond. This is 1 foot. Okay, so that's a standard gastric bypass. We did not take out anything. Everything is still there. The operation works mainly because the upper pouch is small. It's about this big. Holds about half a sandwich. okay, and not half a submarine sandwich, but half a white bread sandwich, and you're full. By the end of the first year, maybe a whole sandwich. Most days you won't be able to finish it. Or a meal that's about that big, a little piece of chicken, little rice, little beans, less than a cup, and you're full. This part of the stomach wall is very muscular, doesn't stretch good. When it starts to stretch, your brain will feel full. There is no more room. You're completely done. Put your fork in the sink, done. Some patients after this tell me that if they're chewing on something and they notice that they're starting to feel full, they'll take their napkin and sneak out what's left in their mouth. That the difference between full and uncomfortable is small. So listen to your body. When it says full, no kidding. Now, I haven't had this, and for me, full means slow down and start planning dessert. It doesn't mean done. It just means slow down. This is the stretchy part of the stomach. This is called the greater curve. This is called the lesser curve. This greater curve will stretch all the way into your pelvis on Thanksgiving or Pizza Hut nights, at times we really overdo it. But this part of the stomach wall doesn't have those kind of stretch fibers. So when it starts to stretch, your brain feels full. There's no more room. Okay? If you keep eating, food stacks up in your esophagus until you hit that burp reflex, and then it'll be in your hand. Okay? So listen to your body. When it says full, you have to quit. Now, this opening between the stomach and the intestine, I make it 12 millimeters, about a ½ inch, about the size of an M&M, so that the stomach empties solids slowly, so that you get a feeling of fullness during a meal. You feel full, you feel satisfied, I'm done, a couple hours before you feel like eating again. Controls the rate of emptying of solids. Now, because that opening is restricted, though, you have to understand that anything that you swallow bigger than that, hunk of apple, steak, anything bigger than an unbroken up M&M is coming back up. So chew your food completely. Most women chew good. Us guys, we rip off a piece, mash it twice to make it wet, bend our knees, close our eyes, and swallow. And that won't work. That has to change. And sometimes it takes a little while to make that change of lifetime behavior. Don't eat when you're driving. Don't eat when you're mad. That's when people tend to mess up, because they're not thinking about the mechanics of eating. They're thinking about everything else. Okay? So it's sometimes the habit of sitting down, take a breath, say a prayer, let go a little bit of the rush of the day. Don't bring it in the meal. Don't take it out on the food. And that's a new behavior and something you might want to start working on while you're getting ready for this. Normally food goes this way. This muscle lets out just a little bit at a time, even the liquids, and immediately it mixes with the bile from the liver and the enzymes from the pancreas. Now the food is going into this 5-foot limb without those digestive enzymes and without that opening and closing muscle mechanism. Because of those changes, most people after bypass surgery will find that foods that are high in fat, foods that are high in refined sugars, things we would call sweets and greasy foods, make them ill. The high-fat, high-sugar foods irritate this first 5 feet, makes you feel shaky, sweaty, crampy, nauseated, rushy, growly, like you ate something spoiled. Lasts about an hour till the food makes it down here where the digestive enzymes are mixing in, and then everything tends to settle down. In fact, there's still enough length to absorb all those calories in the lower part, but next time you see that food, hopefully it won't look as good. Imagine it's kind of like getting food poisoning from chicken salad. It's a long time before chicken salad sounds like a good idea after you go through that dance. So, all fried foods, anything cooked in oil, mayonnaise, salad dressings, butter, sour cream, high-fat meats like ribs and bacon, salami, cheap hamburger, fast food hamburgers, half fat. That's what makes it so good. All desserts, all pastries, all cookies, cannolis either have too much sugar, too much shortening, too much butter fat. That's what makes them so good. So after this, your dessert is strawberries. You can have chicken or fish, cook it on the grill, bake it, broil it. You can have vegetables, you can't bread them and fry them. You can have pasta, you can't have an Alfredo sauce, it's the fat. So you learn how to make a great marinara sauce, and you learn how to make great meatballs out of ground turkey. Instead of deep fried perch with tartar sauce, that old Michigan standard, you have your fish on the grill now, but you learn how to make a mango salsa to make it moist and interesting and zippy without having to fry it or use a mayonnaise-based sauce. Different style of cooking, different than what we grew up on. Real fruits, real vegetables, lean meats cooked in a lean way, and the sheriff goes home with you, and he's there every day and every night and every weekend and every Christmas and every birthday, and No matter how special that day is, that cake will make you sick because it has too much sugar and too much butter. So this shaky, sweaty, crampy, nauseated, rushy, growly is called dumping syndrome. This term dumping syndrome was actually coined in the 1950s during a time when we used to do a lot of ulcer surgery. Remember when people used to have bleeding ulcers? Before these wonderful new medicines like Zantac, Pepcid, we actually had to take out the lower half of the stomach for that ulcer to heal. Very similar operation, just a bigger pouch. And for the same reason, those patients after that surgery found that they couldn't eat anything sweet or greasy, and that was called dumping syndrome, and that was considered to be a complication after their ulcer surgery. These poor patients can't enjoy these wonderful foods anymore. And they usually turned out to be lean adults after that. And people think they were lean because they had half their stomach taken out. They're actually lean because of the food choices they're making. And so this is gastric bypass. This has been the premier operation since the early 90s. It's been done since the 70s. What's different now is we do almost all of them with the scopes, which is a lot easier on you. So that's gastric bypass. Small pouch, small meals, makes you intolerant of the high-fat, high-sugar foods. Now, the other operation that has become the most popular operation in the United States for bariatric surgery is called a sleeve gastrectomy. And the sleeve gastrectomy was initially designed as a two-stage operation. It was the first stage of a two-stage operation for people who were too big to have this done safely with the scopes. 500-pound guy. Can't even reach around him anymore. This part down here starts to get to be pretty tricky and dangerous. But what we could do is go into his upper abdomen where he's not quite as thick. Esophagus, stomach, small intestine. Go into his upper stomach where he's not quite as thick and identify this muscle. Looks like a little bump on the outside. Measure back about an inch, inch and a half, and then with our laparoscopic staplers, we would make a firing like this. Now the stapler is like a long nose pliers, goes behind the stomach, in front of the stomach, closes, presses the front wall up against the back wall, lays down 6 rows of staples, cuts in between row 3 and row 4. Okay? And then anesthesia would pass down a tube which was about as big as your little finger through your mouth while you're asleep. And then with the stapler, I would hug that tube, working my way up the stomach until we had separated the main body of the stomach from this long sleeve. Then this part comes out. I take it out. I give it to the pathologist. They look at it to make sure there's nothing bad in there. And then unceremoniously, they throw it away. So it's gone. Forever gone, gone. Can't get it back, gone. And then we take out the tube. And I usually oversew this with a suture because I'm a nervous guy. So that's the first stage of the sleeve gastrectomy. Operation works for 2 reasons. One, very small gastric reservoir. Only holds a very small meal. Took out the stretchy part. Secondly, there is a specialized group of cells in this part of the stomach wall here, right about here. These cells make a hormone called ghrelin. And ghrelin is the hormone that gives us appetite. It's a hormone that makes us think about food, feel like eating. And when we take out this part of the stomach wall, big time appetite suppression. Patients tell me they have to remind themselves when to eat during the first year or 2. You're like, oh man, 9 o'clock, haven't had any supper yet. Well, I better eat something or I'll feel wimpy in the morning. You know, where food becomes fuel and you have to remind yourself what to eat and when. Okay, so big time appetite suppression, small meals. So we do this 500-pound guy and we get him through it. That's a death-defying leap right there. And after 2 years, he's down to 280. Everything is different. Everything is better. But he's decided he wants to be 180. So now maybe we can go back with our scopes and do this and then bring this end up and now we have this. And now he has this to help him with his food choices. Or we could do a more severe malabsorptive operation called a duodenal switch. But what we're finding now is that if we offer sleeve gastrectomy not just to the biggest of the big, but to all bariatric patients, and we practice modern bariatric surgery, we have the audacity to tell you, you still have to change. How you shop, how you cook, how you manage your stress, how you soothe and comfort yourself, how you find time in your busy life for exercise. And the patients that are able to take this as the time in their life when they're able to make these changes, I think it's very unlikely they're going to need the second stage. So I've done hundreds of sleeves now. I've done 4 second stages. Maybe there'll be more in the future. But for most patients, sleeve gastrectomy is turning out to be a 1-stage operation. And this is it. Second stage is available if you need it. And going from the sleeve to the bypass is pretty straightforward. The hard part's already done. This has a second stage. Every operation has a second stage, but you really want to be successful with one operation because the secondary operations are always at least twice as dangerous as a first operation. But every now and then somebody will need some more help and we'll help them with that. But for most patients, sleeve gastrectomy is turning out to be a 1-stage operation. Maybe there'll be more in the future that'll need a second stage, but we like the sleeve gastrectomy. Patients do very well with it. Which one you pick is kind of up to you. Each one of these has its advantages and disadvantages. This takes 70 minutes. This takes 40 or 50 minutes. Kind of a reflection of the complexity of the operation. This has a connection here that I have to make, a connection here that I have to make, no connections. Each one of these connections, just like any welding job, any plumbing job, could potentially leak. And leak is the boogeyman. Leak is the thing we worry the most about. Something we see now, probably about 1 in 300 primary cases. Usually up here a little corner dies or one stitch cuts through or it's just not tight enough. And so what's leaking here is what you swallow. So it has all the bacteria from your mouth now free in the upper abdomen. So if there's a leak, we almost always have to go back and fix it. And the thing we've learned about leaks is they don't happen very often. I worry about it a lot more than we actually see. But the earlier we identify it, the earlier we get you back to the operating room to fix it, the better you do, the less interruption in your clinical course. And early to me is like, everybody's smiling. This one's not smiling. I'm worried about that one. Or everybody's walking fast in the hallway. This one's really slow. Let's look at Pokey again. Find out why Pokey's not getting better as quickly as everybody else. You know, that's when we want to intervene. And if we think twice about it, if we're really worried about it, this patient just doesn't look good. Everybody looks great. This one doesn't look so good. Probably going to put the scopes back in and look because that's our opportunity to fix it. This is a long suture line, a long staple line. A long weld has a higher risk of leaking than a short weld. So leak, again, is the thing we worry about over here. Probably going to end up being about the same as this. And the thing about the sleeve, if anybody says, what's the downside of a sleeve? I would say that if there's a leak, it can be more difficult to manage, more difficult to get to close. And that's why we really worry about that. Probably the most common complication we see in modern laparoscopic gastric bypass is that in some patients, this opening between the little pouch and the intestine, when it heals too small. I make them all 12 millimeters. I know it's 12 millimeters because there's a 12 millimeter tube through there. I put in my last stitch, I tie my last knot, then we slide out the tube. So it's 12 millimeters. But this is living tissue. It's been cut and sewn, so that's a rough day. Cutting and sewing is an injury, so it's going to swell for a while, just like if you had eye surgery and next week it'd be out there. And that swelling actually makes that opening tighter. That's why it's clear liquids in the hospital, full liquids for 1 week, pureed, baby food stuff for 1 week, soft, everything cooked for 1 week, general diet, just to let the swelling go out and let that opening heal. And in some patients, I think during the liquid phase, it actually heals just big enough for liquids. And then when it comes time to get to solids, to get back to healthy groceries, nothing feels good. And this is a patient who's 5 or 6 weeks out, been home, but just can't make that jump back to healthy groceries. And that's the bottom line, okay? That's where we're going. We're going back to healthy groceries, lean meats, real vegetables, real fruits. And if you can't eat those things, something's not right. Okay, we're not talking about yogurts and protein shakes and stuff like that. That's in the beginning, but eventually we're going back to healthy groceries. And if you can't make that jump back to real food, let me know. And what we do is we look down there with a scope, and sometimes instead of being 12 millimeters, now it's 4 millimeters. When that happens, we call that a stricture. Just means abnormal narrowing. And while I'm looking at it through the scope, I have a balloon, like an angioplasty balloon. I can pass through the scope, across the opening, stretch it out to 15 millimeters, and that usually takes care of it. You go home in about an hour. Okay, but you got to let me know about it. Okay, don't sit home vomiting. If you're vomiting, either you just wolf something big down and that was a learning experience, or something's not right. Let me know, okay? And usually we can deal with it with a single outpatient endoscopy and balloon dilatation. Now, with the sleeve, we can also get strictures. In the beginning, every now and then we'd get an area that was a little bit too narrow on a patient. But what we're seeing now, every now and then we'll get some patients that instead of this thing being like a nice gentle bend like that, it goes into a turn, a kink, like an L. And this gets tight and food doesn't feel good there, and we have to do something about that. But as far as these, just an area that's too narrow, I haven't seen one of those in a while. If you make this sleeve really big, almost never have any strictures. But the weight loss isn't very good. Same thing here. I can make this opening as big as your intestine and decrease this. This is probably about 1 in 50 now. Can make this really big and have less strictures, but you never feel full. So the art of this, the thing that I think really takes the experience, the hundreds of cases, is especially for the sleeve, making the sleeve small enough that you get good functional weight loss without complications. That's the touch part, I think. So leaks can happen, strictures can happen. A small meal should make you comfortable. If it doesn't, let me know. Some vitamins and iron are most efficiently absorbed in this first part of the intestine, and the food doesn't drive by there anymore. So because of that, after gastric bypass surgery, we're going to ask you to take a good quality multivitamin with iron for the rest of your life. We'll send you home on a Bugs Bunny children's chewable. 6 weeks, switch to a Centrum, a Myers, a Rexall. They're all pretty much an overdose. But it's going to be a two-step process now. You're going to have to both buy them and... Yes. And if you do both steps, the vitamin deficiencies are pretty easy to control. But for the rest of your life, a multivitamin. Iron is most efficiently absorbed here too, and the food doesn't drive by there. So every now and then we'll get a patient who's now 5, 10 years out who will have some troubles with iron and iron deficiency anemia. And if we do, it's usually a young woman, super heavy periods, kind of been borderline anemic her whole life. And now we just can't reach an iron balance, iron in versus iron loss, until we get those periods under control. Hormonal manipulation, uterine ablation, or even hysterectomy sometimes. And when I see a new patient, and this is a young woman's got a lifetime of periods ahead of her, maybe childbirth ahead of her, sometimes I try to lean them towards the sleeve, because the sleeve doesn't have that same iron and vitamin problem. Because the food is going in the normal direction here, we try to get all the sleeve patients to take a good quality multivitamin during the rapid weight loss. Seems reasonable. But with the bypass, you're committing to that for the rest of your life. And if you're 20 years out and decide, I don't want to do this anymore, you can still get into trouble with that. And we monitor those things. Let's see. You know how our stomach, when it feels acidy, having a glass of milk, a little ice cream, half a sandwich, kind of settles it down? That food is mixing with the acid, buffering the acid, neutralizing the acid. Well, the food never goes where the acid is anymore. So this part of the stomach is perpetually empty. And normally that's not a problem, except for two situations. One is patients who are chronically taking the ibuprofens, Motrin, Aleve, Advil, and smokers. So the non-steroidal anti-inflammatory drugs and smokers increased ulcer risk. Almost everybody that comes to us is taking these things regularly now because this 100-pound backpack is killing your hips and killing your knees and killing your lower back. I think you'll find those things get better very quickly as the weight comes off. Somebody with a bad condition like rheumatoid arthritis, where they just have this autoimmune arthritis, they're disabled without these medicines, or hip is already finished, knee is already finished, and they're disabled without these anti-inflammatories. Sometimes I try to lean them towards the sleeve, understanding that they're probably going to need these medicines in the future. Somebody who's been a lifetime smoker, started smoking when they're 10, now they're 50. Yeah, we try to get you to stop smoking to control the risk of the surgery, but good chance it's going to start again. Tough addiction. You know, sometimes lifetime smokers, I also lean them away from the gastric bypass to avoid this ulcer risk, because this is probably the main reason we have to reverse a gastric bypass, is ulcers that just won't heal. And this is reversible. Everything is still there. It's a big deal to do it. 5 or 6 times in 16 years I've had to undo one. So it's really uncommon, but it's usually those are the problems. And they just get an ulcer that will not heal. Less of a problem here because we don't have that empty stomach. We have the ability to buffer it with food. And if you look at a series of 10,000 gastric bypass patients in the medical literature, the weight loss now is probably reported to be about 60% excess weight loss in the first year. 100 pounds overweight, 60 pounds in the first year is average. 200 pounds overweight, 120, 130 pounds in the first year is average. The exercisers do even better. People that are really into healthy food choices do even better. This is just the average patient. People that can't exercise, hip is already finished, knee is already finished, back is finished. Never have, never will, and you can't make me. Don't do as good. People that cheat on their diet don't do as good. You can make this go away one chocolate kiss at a time until you've developed a tolerance to those things again. So don't play with it. Don't mess with it. Be afraid of it. Run from it. Hide from it. Be very afraid. Clean out the house. Safe house. Ever heard that in the addictions world? Safe house? You know, I think if you're a family, you do this as a family. If one person in this house is having bariatric surgery, everybody in this house is going to eat better. You know, it's like figuring out, oh, I guess mom is an alcoholic. Rats. Well, first thing we ought to do is clean out the bar in the basement. I built that bar myself. I like having my friends over, watch the Cubs, have a beer. But we're a family. Because we're a family, there's no booze in this house. Period. And same thing. You take the same approach. Clean out the house. Safe house. Healthy house. Now with the sleeve, food is, you know, small gastric reservoir, small meals, big time appetite suppression because we remove that hormone source. And this is usually for the first year or two. Appetite is such an important survival mechanism that if you turn down one appetite mechanism, pretty soon another one will become amplified. That's why diet medicines don't work for very long. And so big time appetite suppression, small meals, but the food is emptying normally. So with the sleeve, we don't have this dumping syndrome. Some people, that's why they want the sleeve. You know, on the holidays, I still want to have these special holiday foods, or on weekends, I want to, you know, ease it up a little bit. Other people say, well, maybe that's where I need most of my help, is on the holidays and on the weekends. But the dumping syndrome is not here with the sleeve. So with the sleeve, you could sip on milkshakes all day long, not lose an ounce. You could eat chocolate all day long until you exploded. I tell people, you know, if you need to defeat the sleeve, safer when you were big. Go to bed with a bag of cashews. Watch a movie, one at a time. You won't lose an ounce. You know, that's a little tongue-in-cheek, but the bottom line is you have to stay away from those kind of behaviors if you choose a sleeve. And what the sleeve will help you with is small meals, no seconds, no feasts. Okay? You got to make good food choices. But if you go to bed with a bag of chips at night and watch TV, your weight loss will be very disappointing. So you have to stay away from those things. For patients who have adult onset diabetes, the literature is now saying about 90% are able to come off their medicines by the end of the first year with a gastric bypass. How cool is that? 90% resolution of adult onset diabetes with a gastric bypass. Now with the sleeve, it's not as fast, and I mean, these gastric bypass patients, we send them home from their operation on half of what they came in on, half of the diabetes medicines, even without any weight loss, because this part of the intestine is being bypassed. There's some neurochemical changes that make the diabetes better right away. With the sleeve, it really has to do with your weight loss. So you do good with your weight loss, you do good with your diabetes. Some people used to say that, well, if they're diabetic, they ought to get a gastric bypass. But I don't know that that's really necessary. It really has to do with weight loss. Now, somebody that has real bad acid reflux, real bad heartburn, starting to get some damage to their esophagus from years of heartburn, almost 100% cure rate here because there is no acid in that upper pouch. Somebody that has bad heartburn but wants a sleeve gastrectomy, at the time of operation, we're going to look very carefully. There's a pair of muscles that guard where the esophagus goes through the diaphragm, and sometimes they get weak and cause what's called a hiatal hernia, where stomach is actually sliding up into the chest. Positive pressure in the belly, negative pressure in the chest, and stomach's being pushed up. And when that gastroesophageal junction gets up into the chest, then that's when the reflux happens. And somebody that has symptomatic reflux and wants a sleeve, we're going to look really carefully at this at the time of operation, and if there's a hiatal hernia, I'll fix it. Adds about 10 minutes to the operation. And that's given us good control of the reflux. You know, if you take anything in nature and study a big enough population and graft your results, it always looks like this, right? Normal distribution, bell-shaped curve. Everything in nature is like this. Heights of men. Here's me. Here's Shaquille O'Neal. Here's mini-me. Sizes of amoebas. Times in a 100-yard dash. Everything always looks like this if you have a big enough population. And if we look at our weight loss, it's about the same. If we say this is the median and this is with the sleeve, it's now reported to be about 50% excess weight loss in the first year. Exercisers do better. People that are really into healthy eating do better. But if we take our results and graph them, it'll always look like this and say this is the 50 to 60. These are the exercisers. They've done better. These are the exercisers who are real careful about their diet. These are the people who are sedentary, can't exercise, won't exercise. Never have, never will, you can't make me. Hip is already finished, knee is already finished. These people over here, and they haven't done as well as the average, but they're medically much better, just with that much weight loss. These people over here, they're sedentary, and they cheat on their diet. Just too stubborn to change how they shop, how they cook, foods they have available in their house. And they're not very happy with their weight loss. But they all had the same operation. So there is this behavioral component to it. At least that's my opinion from my observations. So if this is something you're still interested in, then the next thing we do is we go back over to the office where you came in, and I meet with each one of you individually, go over the medical history you filled out, listen to your heart and lungs real quick, need about 15 minutes each. Is this reasonably safe? You know, is their heart safe enough? Is the lung safe enough? Is it reasonably safe to do an operation of this magnitude? And then if it looks like this is a good idea, then we start to work with your insurance carrier to get permission to do it here. And then once we have that, we work to pick a date. Now, a week before surgery, everybody comes back here for a half-day visit. EKG, chest x-ray, blood work, the routine testing we need to do for a general anesthetic. You'll meet with our internal medicine doctor, Dr. Vaintrub. She'll do a good exam on you that day, a more complete exam. She will help us take care of you while you're in the hospital from the internal medicine standpoint. She will help you plan your medicines when it's time to go home, what to come off and when, what to stay on. You'll meet with our nutritional therapist. She'll talk with you about what to eat while the stomach is healing. There's always some swelling around here, makes this artificially tighter the first couple of weeks. Same thing here, this whole thing is swollen because we cut and sew it. So clear liquids in the hospital, full liquids for a week, pureed baby food stuff for a week, soft everything cooked for a week, regular food, kind of like a broken jaw diet. She'll have that all written out for you, what to eat when, and some recipes so that during the liquid phase you're getting enough calories, enough protein to feel good and heal things. At least 7 days before operation, everybody stop any kind of ibuprofen medicine. And these medicines, ibuprofens and aspirin, through our bloodstream also affect how blood clots. And one dose affects blood clotting for about a week. Now everybody knows how to stop the ibuprofens, but the key is to watch out for hidden aspirin. Things like Alka-Seltzer, Contact, even Pepto-Bismol has aspirin in it. Asper-Cream, Asper-Gum. We have 2 pages of over-the-counter things with aspirin in them. So the week before, you read the box on everything. Make sure it doesn't say aspirin anywhere. We want blood clotting normally for big surgery. Bleeding can be a serious problem if the blood is not clotting normally. Next time you see me is a day of surgery. This takes about 70 minutes. This takes 40 or 50 minutes. You go to the recovery room. I'll come out and find your family, let them know you did okay. About 3 or 4 hours after surgery, we have everybody walking. The most important thing that you can do to get through this is to get out of bed. The main reason why an otherwise healthy, young, beautiful person would die from this, blood clots and pneumonias. And it's the same risk as if it was a C-section, appendix, gallbladder, and it has to do with time in bed. So by 3 hours, our nurses are getting everybody up. Okay, if they don't have you up by 4 hours, I have to come get you up. If I have to be involved, it's a little bit noisier. There's a free motivational talk at the same time. Now, somebody in my family, if one of my brothers or sisters was having this surgery, knowing what I know about it from what I've seen every day, I'd be there. I'd get a couple days off work. I'd get a hotel room nearby so I could sleep at night. I'd park myself into the chair next to their bed with a good book. I'd keep them stoned on the pain medicine so nothing bothered them. But about every hour, well, 10 o'clock, what do you say we go for a walk? Help them up, make a lap around the nursing station, take some deep breaths, take some more drugs. You got the button, you got control of the pain medicine. So you take what you need, okay? And calm and comfortable, that's your target. You take enough pain medicine to make yourself calm and comfortable. If you're anxious, if you're suffering, you need more. But that also makes you lazy and sleepy. You know, narcotics do that. So it's nice to have somebody who's with you during the day who understands how important it is we keep moving. That's what I would do for mine anyway because I'm a nervous guy. Now, so the first night everybody's just doing laps. I would recommend a nice robe and some slippers or tennis shoes, something to cover your backside. Gym trunks. In the morning, we go down to X-ray land, have you drink some stuff. We're watching it go down and through here, make sure that this is open and that there is no leak there. Make sure that this is open all the way down, that there is no leak anywhere along here. X-ray looks good. We start you on sips of water, popsicles, Jell-O. About half the people are going home that afternoon on day 1 or the morning of day 2. Whenever you can tolerate liquids and it sounds like a good idea, that's when you go home. 2 weeks, come back to the office, check the little wounds, meet with our nutritional therapist. 6 weeks, meet again come back to the office, meet with nutrition, meet with me. You should be on general diet by then. Good time to talk to nutrition again. You're back to real world foods. 3 months, meet again, check some vitamin levels at 3 months. And then after that, I want to see you once a year. And I want to see you once a year for as long as we can. We'll talk about eating disorders and stress management. Eating disorders, normal, intelligent, educated, hardworking people who can do whatever they want except control their weight even though their life is in mortal danger. Could call that an eating disorder. And I know one thing that's for sure is that when I do this operation, especially when I do it with the scopes, I almost always forget to cut out that eating disorder. I'm going to wake up with one. Same person, same childhood, same family, same job, same stressors, same stress management tools. Those are the things we have to keep working on. Any one of these operations, from the most complicated and most effective to the sleeve, even the lap band, the simplest and safest, still can turn lousy. Just one bad thing after another until it turns into a death. You need to hear that one time. Okay, but understand that the probability of that happening is very small. Less than 1 in 1,000, but not 0. You just can't do operations of this magnitude in this population with no risk. If anybody tries to tell you that, run. I don't know anybody that does it safer than we do. So do your homework, do your research, check us out, check me out. This is the information age. Do due diligence to get to a good, safe center. And when you figure out that operation's probably safer than not having the operation, then you're ready. Now, if you want to have this done with the scopes, and you do, the most important thing you can do so that I can do this laparoscopically is to come in for operation weighing less than you weigh today. 10 pounds less than today. And it has to do with our friend the liver. So if this is somebody's belly, we won't say whose, spleen's over here, diaphragms are here, heart's in the chest, lung here, kind of a normal stomach-liver relationship. But if you're gaining weight, 1 pound a month, 12 pounds a year, 120 pounds in 10 years. If you're gaining weight, the liver looks like this on the inside. It's about 3 or 4 times its normal volume because of fat within each individual liver cell, fat in between the liver cells. That's what this fatty liver disease problem is. That's why when we're gaining weight, it's always fuller up here. When we're gaining weight, we can't breathe and tie our shoes because this big liver's being pushed up into our chest. And the main reason I have to go from the scopes to an incision is I can't see behind the liver. The liver fills the upper belly cavity almost like a cast of the inside. It takes up all the room. Now, if I make an incision from the bottom of your breastbone to your belly button, I can usually rotate the liver out of the way and do my work. But with the scopes, the belly is closed. There's no room for that. And so that's what this is about. And we'll talk about this on the morning of surgery. I'll say the first thing I'm going to do is put in a scope around your belly button and look around. And if this looks safe, I'll do it with the scopes. If this looks like a really bad idea, what do you want me to do? And at that time, the choices are take out the scope, put on a Band-Aid and send you home, try to lose a little more weight, come back another day, or make an incision and get it done today. And believe it or not, on that morning, almost everybody says, don't you dare send me home without this. We're going to get it done today. And having it done with an incision is not the end of the world. We used to do them all like that. But having a complication because I couldn't see, that could start to become the end of the world. So it's my call during the case. And if at any time during the case, the little birdie that sits on my shoulder goes, this approach is seriously endangering this patient, right in my ear, loud and clear. When I hear that, we usually switch to an open operation to get you out of trouble. And it's almost always somebody's gained a bunch of weight. So don't make every supper the last supper. Know what I mean? Not one more world's greatest pizza, one more banana split, one more, special meal. This journey that we're going on to give you your health back, to give you the quality of the rest of your years back, starts right now with this educational effort. So do the South Beach, do the Atkins, do the OptiFast, do Weight Watchers, do anything that has worked between now and then to bring your weight down. Start a walking program, get the bike tires aired up. It's beautiful outside. Good time to exercise. Start a walking program. Train for this like you're training for the fight of your life, because you kind of are. Come in as fit and as strong as you can with your weight down a little bit. Let's stack the deck in our favor. Okay, now somebody who comes in for surgery weighing 20 pounds more than today also tells me that maybe emotionally they're not ready for this. You did that on purpose. You know, there's reasons why you did that. An absolute recipe for failure, I believe, is to close your eyes, throw your head back and say, "Doctor, wake me up when I'm thin." Doesn't work. It really doesn't work. You're not going to have this fixed just because you had this surgery. Okay? It's going to help a lot. And during that honeymoon period, when the weight's coming off like crazy and you feel like your feet aren't even touching the ground, spend some of that good energy getting to the bottom of what made this necessary. And those are the patients that really do well. They just start to learn more about this, make themselves more sophisticated at understanding this illness, and start to change the things and heal some things. And sometimes you have to go all the way back into childhood. I mean, sometimes there's some serious injuries that happened to our spirit when we were young that started this mess. And you have to go back and find somebody to help you with that. Okay, most people whose job does not involve heavy labor, heavy lifting, or pushing can be back at work in 2 to 3 weeks. People that own their own company are back in 4 days. People that hate their job but have great benefits, 3 months. Same operation, you know. And everybody's somewhere in the middle. So when I see people at 2 weeks, the gunners are already back. The people that got to get back, want to get back, need to get back are already back at work. But I think you'll find that an operation of this magnitude, whether we do it with the scopes or whether we do it with an incision, really lets the wind out of your sails for about a month. Anybody who's had major surgery, had their gallbladder out, a hysterectomy, knows what I'm talking about, where by noon you're exhausted and you just got to lay down for a little bit. And that's okay, but I think the sooner you get back, the better your strength will return. The sooner your strength will return. You know, if you go home on Saturday morning from surgery, on Sunday morning, I want you outside. You know, walk to the corner, walk to the bottom of the driveway. We send people after their heart attack, we send them to the mall. You know, so in the winter, that's where you go and just start your walking program. First day, stay active, get moving. Blood clots and pneumonias will follow you home if you just go to bed. All right, anybody here had bariatric surgery? Anybody here living with this operation? I always like to ask that. I haven't, you know, to see if anything I said was not what they lived. But these are the things that I've learned along the way, things I've learned from talking to my patients. I want to share them with you, see if we can get you through this and dodge most of the potholes. All right, any questions? Anything you heard that didn't make sense? Yes, ma'am.
No, not like I was wondering, you didn't talk about the smokers, because isn't it where you're not supposed to be smoking?
Well, if you're smoking, it affects the risk of the surgery, you know, pulmonary complications. And for young people who are smoking, we do our best to get them to stop smoking. But anybody that already have lung disease or have, you know, heart disease and continue to smoke, we won't do them until they stop smoking. It's kind of like, okay, first you stop killing yourself, then we'll help you. You know, you got to be involved. It's got to be your time to start changing. It's, you know, you hear about this 50-year-old vice president of the company, works about 100 hours a week, no time for exercise, super stressful job, things aren't going so good at home, packing a half a day he thinks nobody knows about. You know, now all of a sudden he's got chest pain. Goes and sees his doctor. Doctor gets him right over to the cardiologist. Cardiologist pops him right in the hospital. He doesn't look so good. Does a cath on him the next morning. Serious blockages. Ready to have the big one, the widowmaker. So they call in the world's greatest heart surgeon. He comes in and takes some veins out of the legs and bypasses those blocked areas to the heart muscle, and chest pain's gone. You know, a few weeks he's back at it. But if he doesn't change, in 2 to 3 years he's in big trouble again. And bariatric surgery is a lot like that. We'll help you get back, but then you got to drive. Okay? And lifetime, that's what we're talking about. That's our goal. good health, normal health, control these other illnesses, get to a normal weight, and enjoy the rest of your life. Have a ball. What else? Anything else here you didn't like?
I have a question.
Yes.
When you were drawing this picture here, how you bypassed the liver, the gallbladder, and the organ on the right there, I forget what it was.
Pancreas here,
The pancreas.
liver, yeah.
Okay, now, are we bypassing those functions as well?
No, they're continuing to work normally, and they're getting added in downstream. But because of this delay, that's the thing that causes people to be intolerant of the high-fat, high-sugar foods. But then the bile from the liver and the pancreas enzymes are mixing with the food down here.
Not in the stomach.
Not right out of the stomach.
Right out of the stomach, yeah.
Not right out of the stomach, like nature made it. Yes?
So it's advised not to eat even healthy fats then, avocados or walnuts.
It's still fat and still calories. You have to be aware of the calories. And you know, you got these people from California, they're growing these nuts like they're growing out of style. And they got to make a living, and they're trying to market them as heart-healthy walnuts. Malarkey. You know, if you're starving, nuts are a good thing to eat because they're super high in calories. Same thing with cheese. And nuts and cheeses and these protein supplements are the main thing that stop our patients' weight loss, is because they really get into this because they're thinking protein, protein, protein. Any protein is good and more is better. And they end up with too many calories. So you got to be aware of these things. And, you know, whole wheat bread is healthy. Well, yeah, you have a better bowel movement, but it still has just as many calories as regular bread. It has more bran. Brown rice, yeah, more bran, but
So what happens to our bowel movements after this?
they should be the same. There's less bulk in the diet because there's less fiber in the diet, because there's less volume. Most people it's the same. Shouldn't change. Now if you go down south and you have deep fried breaded fat balls with gravy, they'll probably run right through you. Ever been there? Been there? Good.
This is with either surgery?
With the bypass especially. And what patients tell me though is they go through this period of really good, careful eating, and then all of a sudden they go back to these bad foods, and they really bother them. And the reason they really bother them is because they're really bad for us. And we get used to them, so they don't bother us as much. And then it's like, you know, going for months without milk, and then all of a sudden you drink milk and you're sick because your body's not used to it. But each step along the way, it'll be a lot of nutritional education. And I shorten it up to lean meats, real vegetables, real fruits. So the super secret bariatric diet, you start out with a little piece of high quality protein, chicken thigh. I use that example because you can kind of visualize the size of that, about 4 ounces. Broccoli, cauliflower, lima beans, sliced tomatoes. Start out, eat the protein first while there's still room, so you get that in, and then vegetables and fruits until you're satisfied. And that's about as sexy as a diet has to get. We tried to patent that. We call that the super secret bariatric, but the patent office says you couldn't patent that. That's what your mother told you you're supposed to be eating. So a little tongue-in-cheek, but again, healthy eating, back to healthy diet. That's just, yeah.
I have a question. What's the average time between like our first meeting with you and actually getting on the table?
It depends on how much work we need to do to get you ready. Like everybody with Blue Cross is going to have to see a psychologist, and that takes a little bit of time. Everybody over 50, we want them to see a cardiologist. Just go and say, I'm going to have bariatric surgery. They want you to give me the once-over so we can get through this without getting booby-trapped by some heart problem. Let them decide what to do. Anybody that has symptoms suggesting untreated sleep apnea will have to get that under control. Once those things are done, then we start to work on a date. And for some people, it's a matter of 2 weeks, and for some people, it's a year. Some plans, like most Blue Cross plans, will require that you will require for some patients that they demonstrate 6 months of medically supervised weight loss before they agree to pay for it.
Right, depending on your BMI.
Depending on your BMI, and people with a body mass index under 50, they do that for everybody. Over 50, it's not necessary. Which sounds cruel, but kind of makes sense. You know, I'll see a patient and I ask, who's your doctor? And I don't have a doctor. I haven't seen a doctor since I got out of the Army. So this is not medically refractory because you haven't worked on it. So that's the other side of that. And everybody's different, but once we have everything done and you're ready, for some young people, they don't need any consultations. They don't need any kind of things to get them ready, and it can be done in a couple of weeks. Unlikely before the end of the year. Kind of, everybody wants to be done before their end of the calendar year. That's getting tight now. You had one more thing?
How many times do we eat a day? 3 times? Or
3 meals, and then in between meals, just a small something. I don't know that you need to think about 6 meals, but I think you need to, in between meals, have a hard-boiled egg, have a mozzarella cheese stick, have a chicken thigh, have a chicken drumstick. Something to keep the metabolism going.
I have a question. If you are like on borderline 50 for your BMI, like 50.1, you lose that 10 pounds between
It really has to do with today's weight.
today's weight?
What's today's weight?
Okay.
The same thing if you're, at 40, right at the borderline. And we have patients who are seen with a body mass index of 41, and then they lose weight to get ready for operation. They come in at 38. They're all worried about that, but that won't be a problem. It's today's weight that determines, because we try to get everybody to lose weight, and a lot of patients do it. And I tell patients that the probability of me being able to do it laparoscopically depends on you coming in with your weight down. Okay? So it's up to you. Doesn't matter to me. I get paid the same for either one. It's actually faster to do it open, but it's a lot easier on you in the long run to have it done with the scopes. I prefer to do everybody with the scopes because big wound problems, small wound problems. What else? Okay, the really good questions will come up on the drive home once you get in the car and start to relax. So write them down. Call us back. Get everything you need to know about this answered, so that I think the more you know, the less anxiety you have to drag through it. All right, so if you want to go to the next step, and there's like 8 or 10 here, patients, and that's 2 hours for the last one. It's the price of having a Saturday thing. Try to do this so that people can come and see us without taking off work, but it gets real popular. If you want to just go home and reschedule for a 15-minute appointment sometime, you can do that, or you can wait. I see the person who signed in first, and the person who signed in last. That determines the order. And but I need about 10 to 15 minutes each. And if this is all you wanted today was this information, you can just pick up a copy of a DVD of this talk on the way out and come see us when you're ready. Okay? Yes?
What if we didn't sign in?
Well, then you're at the bottom of the list. Okay. Oh, yeah.
Pretty sure I'm at the bottom.
Yeah. All right. But if you got time, and we'll see anybody that wants to be seen today and get this started. So come with me.